Hi, Dr. Newman. I'm Suqin Yu from Shanghai General Hospital. Nice to see you again online. Last time was 3 months ago. We had an international dialogue on LHON, and it's my great honor to have this opportunity to interview you this time.
Very great pleasure to be here. Thank you.
Today, on behalf of Chinese eye doctors, I would like to ask you a few questions about the treatment of LHON. The first one is about gene therapy. There is an interesting contralateral effect has been observed with the LHON gene therapy. Actually, this phenomenon was not observed only in LHON gene therapy. It was also observed in other ocular gene therapy programs. When I received intravitreal injection and both sides improved visual acuity. What's your understanding or opinion of this contralateral effect?
Yes, of course, this is a very, very important issue. Back when we were designing any clinical trial for Leber's, we assumed that the eyes would be independent and that we could use the fellow eye as an internal control. And there were many of us who thought that. It was the paradigm for practically every trial, starting with the one I did back in early 2000s with topical bromonidine to try to keep the second eye from happening. And this paradigm for Leber's was always one of its major strengths, right? There isn't another human disease in which you absolutely know for sure that the second eye is going to convert. And in between 50 and 75% of patients, you have a window of opportunity to keep that from happening. So it's been a very sexy disease that way. And a lot of drug companies and people looking to test therapies have used it as a model in that regard, thinking that it was independent in the eyes. And so I take some of the responsibility for our mistake, because I do believe there is a contralateral effect. There are people, including myself, who initially got very worried that maybe we just didn't understand the natural history of the disorder because we really didn't have prospective big studies in which we followed patients without any treatment at all. And so initially I was even skeptical of it, but the robustness of the second eye effect being, again, 3 lines of vision, looking at all the natural history studies, again, showing that this is different than the natural history. The fact that it's across all groups who have tried the gene therapy. So, for example, it's seen in many of the patients in the Miami group. It's certainly been seen in many patients in your Chinese studies, and it's been seen in every one of the studies done with the GenSight group. And I think what finally convinced me was the REFLECT study, which is a bilateral injection study in which every first eye involved received an injection of the drug. And then the second involved eye was randomized to get an injection of the drug, or an injection, not a sham, an actual injection of placebo. And the primary endpoint was designed, before we knew about this contralateral effect, to be the difference between the second eyes involved, placebo versus gene therapy. And in that study, not only were second eyes show involvement that didn't get the injection, but there was a dose effect, which suggested that in patients who received injection in both eyes of drug, did better than patients who received injection of drug in only one eye. And that to me was finally the thing that pushed me over to really believe that there is a contralateral effect. So once you believe it, why does it happen? And that's a fair bit of hand waving. We thought we had the answer when we found that in a monkey study, when you inject the vector in one eye, you found the vector DNA in not only the contralateral eye, but the contralateral optic nerve, and even some of the intracranial visual pathways, suggesting somehow there's transport. However, we have had the unfortunate chance to see it in a human from one of our trials, the rescue trial, who died of unrelated causes. And we did indeed find vector DNA in the opposite eye, retina and optic nerve, but 200 times less in concentration. And the visual acuities in the two eyes were so similar, it's hard to use that as a reason. So I think there's a little bit more investigation. Unfortunately, we have a second autopsy case. We don't know the results of that yet. But now we're thinking maybe things like cortical reorganization, where the eye is, quote unquote, listened to a little bit more intensely by the brain. It's very hard to make sense of this, but I do think it's real.
Thank you. So you already mentioned that a previous study, GS010. So our question, the second question is about GS010. We have learned that GS010 clinical development has come across some major challenges. As a leading PI, what do you think? What is worth learning from it for other gene therapy program?
Yeah, so I think some of the challenges that you're referring to have included regulatory issues, which I'll get into. But I think the main challenge over this last year has been product availability, and that now is back on track. So there should be product availability by the first quarter of 2024. So I don't, that can happen anywhere, any time. And the problem, of course, is that the FDA will want to make sure that the product is identical or similar enough to the first product that you can use the results from the original trials. And so those are all challenges. But the major challenges have been, I think, regulatory acceptance. And I don't blame them to some extent, because this contralateral effect made the primary endpoint not met in any studies. And so that's difficult for regulatory agents to accept. The European Medicines Association, so the European version of the FDA, previously approved idebenone, and we'll get to that a little bit later, as I understand, previously approved idebenone for special circumstances with Leber's patients on the basis of natural history data. There was no, there was the one randomized controlled study of Rhodos, but it didn't meet its primary endpoint either, and it was within only 6 months of follow-up. But they did approve it based on subgroup analysis and natural history data. That same group, however, has concerns about using natural history data for the gene therapy studies. I think it's because the expense and potential invasiveness of gene therapy raises the bar a bit. And so that's one of the difficulties, and I think further studies may be required. The FDA, there's no question right from the get-go, not only are they not willing to accept natural history data as a surrogate for efficacy for the gene therapy, but they have a higher bar regarding two things. One, they expect a 0.3 logMAR difference, which is equivalent to 3 lines of vision difference. As you know, the idebenone studies use what they call clinical relevant recovery, which is approximately 2 lines of improvement. So that's a higher bar. And the second thing is that they require a patient placebo-controlled study, so that you can't use the eye as an internal control. You can't use natural history data. They want an arm, at least one arm, that will receive placebo. And I don't think they're going to budge on that. Originally, they were requiring placebo injections in both eyes of the placebo group, actual injections. We have voiced our concern about that for equipoise, and will likely suggest that the control group, the control patient group, receive a sham injection in both eyes, because they won't have any comparison. So they'll think they're getting real injections, So they won't know if they're getting a real injection or a sham injection as a person. And I think that's, again, recruitment's going to be hard. It's going to be hard to have these patients not be on idebenone. From what I understand, the Chinese group is also considering a patient placebo controlled study, because the only way, I think, to get in the market for the United States is going to be to do that.
Great. Thank you. Very useful information. You already mentioned the idebenone. So the next question is also about idebenone. Yeah, you mentioned it was approved in Europe, but not in other countries. And in China, it is under clinical development. Yourself, I would like to know yourself, do you have any experience with this drug for the treatment of LHON? Can you share with us?
Certainly, and probably right from the beginning, I should have indicated that I am a consultant for pretty much everyone. So I have a consultancy agreement with Genzyme for gene therapy. I have a consultancy agreement with Chiesi and Santhera for idebenone, and I have a consultancy agreement with neuro-opt, with the Chinese group. So I have a vested interest in everybody. I just want to see these patients have something. I've been working on this almost 35 years, and it would be really wonderful if we could do that. So let's talk about idebenone. I do think it does something. Again, the metric, the bar is lower with 0.2 logMAR instead, 2 lines of vision as opposed to 3. It's not clear that everybody is a responder, and there's some interesting things looking into why that is. There is no question that it is safe. It is a benign drug. It's a super vitamin, and it's easy to take, and 300 milligrams 3 times a day with food, and most people tolerate it very well. The only issue is it's not available to the vast majority of people out there. It
also
is
quite expensive.
Yes, it is available online if you're willing to pay for it yourself. I think we're talking maybe about $2,000 a year in the United States if you get it online. Most of my patients do try it for at least 1 year. Now some data are suggesting 2 years would be good. There have been, again, the same barriers, except for the ROTO study. There are no patient-controlled groups. It's been compared to the natural history in the literature, we have even the most recent study, which is the LEROS study, has yet to be published. It's in review. We're all hoping it can come out. But there are issues regarding that study as well. I mean, it included all 3 mutation types. We should point out to our audience that the gene therapy, except for the one pilot Chinese study doing the 3460, the gene therapy studies have all been exclusively using the 11778 mutation, the ND4 mutation. The LEROS study included the 11778 as the majority, but also 14484 patients and 3460 patients. And the 14484 mutation does have a much better natural history prognosis, and so it may tend to skew the data. Additionally, they included patients with onset as young as age 8. And we know that under the age of 12, as onset, patients do a whole lot better in the long run. So there are challenges with that data. And then in the subgroup analysis, I think it's pretty strong for the 11778 that it does something, even with these limitations of patient age issues. It's not so clear for the 14484 because these patients do fairly well anyway. And a slightly disturbing thing that's been reported that and will be published in the article once it's out is that patients with the 3460 mutation, if treated within the first year, seem to do worse than the natural history group that they had. But if you look at that natural history group, it actually includes a couple of outliers who may very well have been young at onset. I don't know the specific data points, but did much better than we usually think of for that 3460. So I'm not sure that it's actually a negative effect. That effect, if you treat them after a year from onset, doesn't seem to be there anymore. So I'm not sure it's a negative effect. There are some biochemical reasons why it might be a negative effect from the Italian group, but it's really unclear about that. So I think it's worth getting idebenone out there, just given the safety profile. The problem is it's 2 different companies. And frankly, from my point of view, I would love to see trials where it's dual therapy, and everybody gets idebenone, and then we, half get the gene therapy and half don't. But companies don't do that. So I'm not sure where to go with that, unless in China, maybe you have a different way of getting idebenone, and you could do that in your study where you have everybody on idebenone, and then you have a control group that doesn't get the gene therapy and a group that does. I don't
know. Great. Thank you. Thank you for your so much information. We don't have idebenone either in China. So very useful information. And I have a last question for you. What is the status of LHON guidelines in the United States?
Well, first of all, we don't have any because we don't have any approved.
You don't have guidelines.
Right. So I think the reality is most neuro-ophthalmologists will discuss idebenone with their patients. I think the best thing we can do for our patients worldwide is make sure that they are aware of the LHON support groups, the lay groups, the websites, and every country seems to have something. There's a very big one in the United States, pioneered by Lisa Poinceneau, LHON.org. And it's a great place for education. It's a great place for support groups for both the patients and the family. It's a great place to register so that if there is a clinical trial, we can recruit with the click of a mouse. That has completely revolutionized, by the way, the ability to recruit for a rare disease. I mean, there's no way we would have the 200 plus patients we've had alone in the GenSight studies, and you've had in China. I'm sure that social media has helped. And it is a great place for links to get idebenone and other things if you're interested. We've had a couple of analyses done. It seems that what's online appears to be the same compound that's being sold, but again, you have to pay out of pocket, and you never really know what you're getting when you go online. So, but I think most of us do tell our patients to go to the LHON.org website and consider idebenone, especially if they're within the first or maybe second year of vision loss, and to continue it for at least 1 year, maybe 2. That's kind of what what data we have would suggest. Regarding gene therapy, we had some compassionate use offered by GenSight, both in Europe, France and Italy, and in the United States. That has come to a close. Right now, there is no compassionate use offered unless you are offering it in China. As far as I know, no one else is doing that. I know that the FDA, as we said earlier, is not going to approve this until they have a treatment-naive control patient group, not just eye group. And I know that GenSight, as you probably know, is setting up what they call the RECOVER study, which will be, again, for subacute early patients, and the REVIVE study in England, which will be for chronic patients. One of the things we haven't talked about, which also was a surprise, was that it appears that, contrary to the intuition idea, or the intuitive idea that the earlier you treat, the better these patients will do with gene therapy, it appears that patients treated between 6 months and 1 year, and even between 6 months and 1.5 years with the compassionate use group, do better than those patients treated in the first 6 months of vision loss. And again, there's a lot of hand waving about why that is. Perhaps the swelling that happens with labors, the metabolic swelling of the nerve fiber layer, can act as a barrier to the gene therapy getting into the retinal ganglion cells. But again, it's just trying to come up with a reason for something we don't understand. So I think RECOVER is going to specifically target that 6 months to 1.5 years, and it will have a placebo group. That's going to take a long time. It probably won't start up because they need the product until Q2 of 2024. I know that China is hoping to get a study going as well. I think that's the only thing that will allow gene therapy to come into the United States. And I don't know what idebenone is going to do. They're going to hit some real regulatory issues. Regarding the European regulatory agency, as you know, GenSight withdrew its request for regulatory approval to have time to kind of deal with some of the questions that were asked. And it may be that needs to wait until the placebo patient group trial happens too. I'm not sure. That may move forward otherwise, but who knows? I don't know. So I think that's the landscape. I don't know of any other, maybe you do, human trials for Leber's hereditary optic neuropathy with any different product or any different ideas. There certainly are animal models happening, with the holy grail being, can you get the mitochondrial DNA into the mitochondrial DNA rather than having to go through allotopic rescue, which is kind of controversial, the idea of going through the nucleus and then getting that product, the protein product, into the mitochondria, instead getting the mitochondrial DNA. And the John Guys, who unfortunately has left us, but has passed, but his group in Miami, he recently came out with a paper in a mouse model suggesting that this may be possible, but that's way far away from, I think, human drug development.
Thank you. A lot of information. So thank you for being with us tonight. I mean, Beijing time. I believe our Chinese eye doctors can learn a lot from our conversation about the latest latest progress in the treatment of LHON.
Well, thank you very much. It's a great honor to be here or there. And I hope you have a good meeting.
Yeah, we really have. We really have. Thank you. Thank you for your time. It's a great pleasure to talk with you. So we hope to see you next time in the near future in person.
That would be wonderful.
And that
Thank
will be wonderful. Yes, yes. Okay, thank you.
Bye-bye.
Bye-bye.